Okay, now we're going to get into the nitty-gritty stuff. I use the term tone over and over again. And tone is, this is another word that therapists like to throw out. And you guys sit there and go, okay, whatever it means to you, I hope it's, viable to what you're going to tell me next. But tone is actually the resting state of the muscle itself. And one of the tones types that we deal with is spasticity. Now, I'm going to give you this example of spasticity, and it's not demeaning to you. It's just I think it's a very good categorizing. When I work with families who have infants and they're new on my caseload, this is the example I use. I take my fingers like this, I put one rubber band around it, and I say, this is my tone. This is normal muscle tone, although I don't have normal muscle tone. And then I put like 5 rubber bands around. That is spasticity. Spasticity is the point of rest that resists movement, resists stretch. In other words, spasticity likes to be the length that it is. So then when you look at this, and somebody will say to me, well, what is this I'm seeing? Is this spasticity or weakness or strength? I'm going to tell you it's both. He's spastic, but also he's got strength. I had another picture of a baby which I took out for this group, but anyway, spasticity is that where there's involuntary reflex activity in response to a stretch. In other words, if somebody's spastic and I pull their arm out too fast, those rubber bands are going to pull it back immediately. That's what they call a stretch reflex. So that with spasticity, just know that there is more resistance to movement, and that if you move them too quickly, it will rebound and give you a stretch reflex.
So when they're like that,
that's extensor tone, but it has spasticity. If you try to move them, you feel resistance. What's another example of spasticity? Clonus. Where their foot starts to go like this. What happens is somewhere they move their ankle too fast and the reflex activity starts going. But just remember, it's like 5 rubber bands. And it gives them a huge amount of strength because in the end range of extension, I'll introduce you to a little boy at the end of this and it'll make more sense. But it's those spastic muscles wanting to go to their shortest position and holding it because they don't like to stretch.
So when they're out, they're extended.
And the extensors are the shortest they can be, and they have the most power.
Like this, they're spastic.
Spastic is, yeah, I know, this is why I put it in the middle. Spasticity is, I think I have another, velocity dependent. Spasticity is the resting state. In other words, I'm 1 rubber band. I'm actually 2 rubber bands, but 1 rubber band would be normal. 5 rubber bands would be spastic. So if I could tie 5 rubber bands around my elbow joint and I would try to move it, I would be moving against resistance because the muscle tone is so much higher to the spasticity. And if I move it faster, I get more resistance. That's what they call about velocity dependent. So that's with a spastic child, why we move them so slowly, because we want to be able to stretch them out. And if you see somebody trying to just stretch them, what you're going to find is somebody who pulls back and gets that stretch reflex and fights you back.
So it's about the resistance. Resistance.
Yeah, it's about the resting state is a very simple way of putting it, but it is the resistance of the muscle itself.
To pull out.
Yeah, or to go in the other. Whereas,
why is that important in terms of seating a person in a chair? How does that principle relate to manipulating a child and getting them properly seated?
2 ways. So when you're dealing with a child in a chair, there are 2 reasons why you want to know about spasticity. One of which is that the child you see may not be the range of motion that child actually has, because they're doing this, they're all curled up or they're all extended, but you can position them in a more typical posture where they can be more functional. There's one reason. The second reason is you don't want to move them quickly, because if you move them quickly, they will pull into more tone. So you want to, move them slowly, and that's where a therapist on a team can come in and say, no, he actually can sit at 90 degrees, even though he's like this. You need to know what his functional range of motion is versus their fixed range of motion.
How does the therapist determine that that individual can actually do that?
Oh, therapists have magic hands. No. A therapist can use a facilitation technique to provide range of motion to try to figure out what the tone is. One of the easiest ways, and you've seen me do it over and over again, I put them in side lying and see if that quiets the tone, and then facilitate him in sitting. This is why I brought my little friend. This is why I have no clothes with me. He takes half my luggage. But he doesn't, okay, this is sideline. So you've seen me do this with kids as I've hold them and I've come over to talk to you, somebody wants to check seat depth, and I'll have a child like this, because what I'm doing is I'm quieting tone. Because when we get into reflexes, which are really hard, and you have extensive reflexes, if he's like this, he's going to be like this. So in side lying, it tends to quiet some of these reflex patterns and normalize the tone.
So if you do that, then you know that they can go to 90 degrees.
Yeah, and that's why, and then they're little enough, like this guy, then you can do that.
So what are you going to look for in a child? And obviously size matters because you can't pick up really big kids.
But I can put him on the mat like that.
You put them on the mat, okay, and you put them in sideline. And so if you see someone that is in extension, then is that an automatic thing that you do with that child
Absolutely.
or with that adult?
Absolutely.
So the first thing you do in the process then would be to put them in sideline and then to see if you can put them into a 90.
That's correct. Or, this is the other thing is, say you put them in your chair and they settle a little bit. Then I go in, and I've seen everybody do this too, where you pivot their pelvis and pull them back in and let them sit. Now I'm not pivoting, I'm doing it very slowly. I'm pivoting the pelvis and pulling them back in their chair, and then I'm waiting. And then doing that and waiting. And as the tone, they still have spasticity, but as they quiet into the posture, as long as I move them, then I can see what the end result is. The reason you do it is because, the same reason the mom puts the boy in the flower pot. You know, she's found that position where he's not like this. And that position, that bunching up of posture, it keeps him quiet. Now, why do you want to do that? Because when he's like this, think of the calories he's burning. Tons and tons of calories. Not to mention, that hurts. That spinal extension is going to give you a spasm and hurt. So that when you get like this and you quiet them, they're not burning the calories, they're not fatiguing, they're not in pain. Well, he might be in pain, that not a flower pot that's padded.
But if they can't do that, what does that look like? They just can't.
They can't. I have a couple pictures, I'll show you what. I mean, you know those guys.
Now, how do I burn a ton of calories without going to a gym?
Yeah, you have spasticity. Yeah, you have spasticity. Yeah, I don't know. I mean, the other thing is, when we talk about strengthening, this is where you'll know something that a lot of therapists forget. When I get new students and they go with me, one of the first things I say to them is spasticity has nothing to do with strength. When you see these kids and they look like Arnold, who I voted for, by the way, before I left the state, when he was a good guy, didn't realize he had a mini-me. Yeah, whoops, yeah. Anyway, when you have spasticity and you look like you're strong, spastic muscles don't have strength to them. They tend to be very weak because they haven't challenged gravity. Normal children, from birth, they challenge gravity so that when you're born and your head is so heavy, you're challenging gravity all the time to develop strength. Our kids don't have that opportunity, and particularly here in the States, as they get older, they put more and more support on them. So when we look at these kids, we think of them as far as muscle strength, being very, very weak. Not so much in third world countries, because some of these kids have accommodated and done some magic things because we haven't over-supported them. Now, this is where it gets hard, but I'm going to make it easy for you. Okay, now we're going to do easy, okay. 2 kinds of muscle activities. And this is where the extension will make sense to you. There's tonic muscle activity and there's phasic muscle activity. If I go to pick this up, and I am a normally neurologically integrated person, I lift this up and I bring it to up here. When I move, both my agonist and my antagonist, the two opposing muscle groups, are active because one muscle group is providing the movement and the antagonist is providing resistance to give me a nice controlled movement, so I don't do that. So that is a phasic muscle activity, and my nervous system is matured enough that that's how I move against resistance. Our kids and adults who have a more neurologically impaired brain system move in a tonic muscle activity, which means that when they move into, say, extension, only the extensors are firing. The opposing muscle group, the antagonists, are not active at all. So that's why they're allowed to go to this end strange movement with so much power, because there's no resistance. There not only is no resistance, there is no stability at that joint. And that's where it's very, very dangerous. That's where you get deformities creating, because you have this wild extension, no resistance. You get these wild movements in flexion and extension. And it's done under stress too. Now, if I go out and lift up that car, or try, and it's very heavy, I'm going to use my reflex patterns to try to lift, because my nervous system knows I don't need resistance. I already have the resistance of this weight. When you play tennis, or when when I play golf, unfortunately, I'll use my reflex patterns to move. We all will. And let's go over them so it'll make a little more sense. So tonic muscle activity, I already discussed it. Only the agonists are firing, and it's immature. Or increased demand if I go to pick up a car, which I don't likely do. We know what it looks like. Now, in a normal baby, it's a very functional reflex pattern because, again, they're born and they don't have a lot of strength. They're a baby. So they've been given this option to move without resistance, so they can take these weak little muscles and move against gravity and develop things like their visual focal field and bring their hands to their mouth and do all these things. So neurologically, it has a purpose. Once they strengthen and their nervous system increases, these reflex patterns go away. They stay in your brain somewhere, and you can use them as needed. But this posture, so that's a tonic reflex. Phasic muscle activity, again, it's that you have stability and you have opposing muscle groups. So that's why you can stop anywhere in this movement and have stability. Whereas our kids only have either or. And the reason it's important is you have postures that are halfway between things. Slightly forward, slightly back. Looks like Shan was going to eat him. It's just all a matter of balance. Heads are all a matter of balance. I'll go over the reflexes individually, and then it'll make sense, hopefully. Our big, heavy heads, put them in a position where they don't have to work so hard. Because I tell you, if he has to lift his head, he's going to use a reflex pattern to do that because he's not strong enough to hold it upright. And why do you move? Kids have to move. That's the reality of it. They have to be able to move to just cough or change their orientation, or somebody comes up to talk to them. They look up. And there's all these reasons to actually move in their chair. So as a result, because of their weakness, this is a real slide. Sorry, this is a real device. It has a commode bucket too. This is mental health, 1800s. Yeah. But think of some of the seating systems we've seen out there. Are they that much farther from that without the commode bucket? This is a person who's never going to strengthen in their chair. So that we see these atypical postures, right? We know where to put our hands. You look at this slide, you know exactly where to put your hands. And to me, there's nothing magic about seating at all. Period. That's it. Wherever your hands need to be, that's where the components need to be. Now look at this poor little pelvis, little tiny base of support, not much structure here. But I could take my hands and go, and that's all there is to it. People say, well, how do you get results? Well, it's pretty easy. If I can do it with my hands, I can do it with my chair. And so sometimes if you end up on a team with one of those therapists that is really not communicating well with you, not that they're right or they're wrong, but somewhere it's lost in translation. I'll just say, show me with your hands what you want me to do, and then they'll do their thing, and then it'll all make sense. Because most of the clinicians that are on the team with you have good manual handling techniques. They're good therapists, but they're not good with hardware. So, and we don't learn hardware in school. And honestly, some of us are not mechanically inclined. Oh well. So there's your points of support. 3 points of support. Not 2, 3, because they'll get underneath. So always remember 3 points of support. Too bad we don't have 3 hands, it'd be a lot easier. But you can visualize, what your third point would be. Easy. Those kids are easy. And then you set up your chair with your components as you need it. I just think it's nice to see x-rays. Just be well aware that, probably where you're putting your hands is not anatomically perfectly exact, because we're looking at the rib cage and not the spine. But the rib cage is kind of an indicator of, when we say to you, could you put the trunk pad a little lower? Remember, what we're trying to deal with is the spine, not the rib cage. And sometimes what you're looking at is just the cage. I don't know why I put that in. It's interesting. This I put in because every once in a while somebody mentions something and it's good you know it. That's a Harrington rod. You'll never see that in a third world country, probably. But what they do is, it's like carpentry. It has a little hook here and a little hook here and a turnbuckle down here. And they open up somebody from the rear and they put that bar in and it stabilizes the scoliosis. So that they don't continue to compress. Okay, what happens when you get to this? Okay, I need to be an octopus, because I can do here, but then I've got rotation of the pelvis and I've got rotation in the upper extremity. I mean, there's a period of time where you have to compromise and say, look, there's only so much I can do with my chair. Can gravity help with that? You can start pulling other dynamics in. Maybe if I use tilt and gravity pulls that pelvis back, maybe I'm serious about 2 seat belts or a pelvic belt to bring that one hip down. But that's where it's magic to take somebody's shirt off if you can, depending on the country, and see what you're looking at. Because then you've got all these weird dynamics. But again, that's one thing. If you end up with a therapist who has a picture in their mind of what they want, and then you say to them, put your hands, and what would I use to do that movement? Then they kind of go, yeah, I guess it would be really hard to do that. These are frustrating clients, and gravity is a big help with that. This is a double Harrington rod. You probably would never see that, but I just think it's interesting. It's good to learn things.
On the young man that you had in the slide previously, on that young man, and we see things like this from time to time. And so what I would do, let me just tell you what I would do. I would try to put him, he's windswept obviously.
Yep.
And I would try to put him into a tilt chair and then support that one side as much as I could. I don't know how to, on the slide that you have, and I think it's the next one, where you have all of these, slides that are turning him.
Yeah.
I think I'd have to depend on gravity to do that.
Correct.
I don't know what I would do in order to accomplish that motion.
Gravity's the only thing you probably could use,
All
yeah.
right, so
I mean, because a rotational pull.
How far off am I in terms of the assessment on what to do with him?
Not hard at all. And then the only thing to be very aware of is that you don't end up with a pressure point over here.
Okay.
That's I mean,
How
unless
do you avoid that, other than just
some people do carving,
okay.
and they'll do. You've seen Dick do it. You've seen others do it.
Right.
There's a grid back. I used to take with me a foam of 2-inch foam that already had the scores cut out. It looked like just a grid.
Yeah.
And then I would pull out plunks of foam in the field and then put that under the cover. It's a lot easier than carving.
So would you carve out on the other side, on the opposite side to the right, and then put a...
It depends on the client. It depends on the
On
client.
that one, you would have the thinnest part of the pad where the shoulder comes out.
Yeah, but support around
And
it.
then and support the spine.
So you wouldn't put a abductor on the left side and try and move him, just try and get him.
I don't know how, see, there's the thing you don't know. You know, we have a flat picture. I don't know how much of this is flexible.
So if he's not flexible, you wouldn't try that.
Yeah, yeah. But if he's flexible, I want it back because he could only get worse.
Yeah.
You know, and you know, we'll see these cases, and you know, there's such a thing as we call it an idiopathic scoliosis, that the kids are born that way. You'll see them; they have these wild rotational curves. There's not a lot you can do with them. But yeah, I mean, you couldn't do this with a belt, and that's what I'm saying. You know, when a therapist says, well, I want you to move this hip pad here and this pad here, remember where the pads are. They're all lateral. So you have posterior support, that's the back of the chair. You have, you know, a seat, and you have straps. But as far as rotation, it's really hard to correct rotation. So, and I've been, you know me, I have a small amount of sarcasm that comes with me. And when people say that, well, I say to them, are you going to run around with them all day and hold them in their chair? Because if you're not, I can't do that with the mechanics of seating. You know, it's unfortunate. Plus, once they get on a bus, you know, then they're going to drop to that lowest point. So, yeah, I mean, there's a limit to what you can do, and this is why, when you see these kinds of wild rotations. But again, if he's flexible, you probably can get some of it back. Now, you talk about windswept deformities and dislocations. This is what it looks like. Don't worry about this hip too much. This one is on its way out to the left field. So what is that person going to look like in their chair? There you go. So if you see a leg length discrepancy in CP, it's usually a dislocation. Now, what I can't tell you until I actually put my hands on her is this a dislocation that is anterior, or is this a dislocation that is posterior? This is the hip I'm going to be really, really, really worried about. Because what happens is, it's going to start migrating. It's going to migrate to the outside, and then it's going to externally rotate. And you know those kids, painful, painful hips. And then you can't bend them to 90 because their leg is so externally rotated that if you bring them back, it doesn't derotate to flex. And they're the kids that you sometimes have to open up the seat to back angle on because anatomically they just can't. So just be well aware, if you have a hip that is rotated out, you could end up with a very, very painful hip. Just a consideration.
So once again, now what do you do?
I open up the seat to back angle and let that hip have the room to be extended. In other words,
Or into a recline.
yeah, because it's a good thing he has a nose. Okay, here he is. He's externally rotated. He's doing this. If I force him into flexion, he will, he'll push back. I mean, I have to be able to rotate him back in to flex him. And once he's rotated out, you can't flex because there's no joint there. See what she's doing is she's rotated out this way. So if I try to flex her at the knee, it's going to be really painful. So what I'm going to do is I'm going to open up the chair a little bit, put a block over here so it can't migrate even more. You've had some of these kids. I mean, we've fit them over and over again.
You want to limit that.
Yeah, I want to limit it, but I can't do it by shutting up the seat to back angle.
But half the time you don't know the leg.
Oh, you'll feel it.
I don't know the leg is shorter until I got him halfway seated, and then the
Yeah.
mother says, "Oh, the leg is short. This leg is shorter." Oh.
Yeah, yeah. Well, what happens is, okay, here you are. Let's see, I got to do it this way. Okay, here he is. You'll feel it. When you pull him back, the first thing he'll do is he'll push back on one side. You'll feel it as you put him in. They will push really hard on that foot plate, on that side. Sometimes you've got the range to do it, but it's so painful, and they can't tell us, unfortunately. A lot of the kids can't. But if they continue to push back against that leg, then try opening up the seat to back angle.
So go back to that again, because I think this is really important. They're pushing back with this leg.
This leg.
Right? Oh, they're pushing back with this
Yeah,
leg.
because they want to extend it.
Okay.
Because it's externally rotated, it's like this.
Yeah. So they'll have their leg on the foot pedal or a foot plate down here pushing back.
Pushing back.
Yeah.
I mean, you'll see it in their trunk usually.
Right.
Because it hurts to flex. because they're already rotated out a little bit.
Is there any place that you can put that you can feel it?
In the pelvis, right away.
Pelvis.
Yeah.
Okay.
Yeah. Usually what happens is you get back there and hold the pelvis, and they're pushing all the time to get pressure off of that hip.
Okay.
Because it's a very painful stretch. Really, really painful.
So the kid's chair will not work for that child.
Yeah, we can put a wedge in. We can, you can change the seat to back angle.
Oh, the back angle, okay.
Yeah.
You can.
Yeah, so you open up the recline that way.
You can drop this back.
Yeah.
So that the back
Right.
of the chair goes down a little bit.
Yeah.
Okay, abduction. I love this. This happened to me in Australia. I went and taught this class. I said, okay, the reason you abduct the kids' knees, move their knees apart, is that you have 3 points of support then, like a tripod, and you have more stability. So I went the next day and they said, oh, come to see our classroom. We abducted everyone. Well, the more you abduct someone, the shorter their seat depth gets. So what happened was, here are their knees before they abducted. Once they abduct, the seat depth anatomically shortens. Okay, go back and remember that thing I said early this morning, that it is so hard to measure children for a couple reasons. Their pelvis is so little. But the other reason is that people forget to measure them abducted. So when you see a team member, and this is where it's awkward for you guys because you have to be politically correct, but if you see a fellow do wheelchair measurement for you, and he's got their knees together and he's laying them on the mat and he's measuring from here to here and giving you that measurement, subtract something, because you're going to abduct them and that's going to be shorter. But with their knees together, it's a real PC kind of thing. So that's why when I get kiddos, what I like to do is you'll see me put them on a table and I'll abduct them to here, and then I just measure from here to the back of their back, and it's just a much better measurement.
To the back of their back or to their butt right
But yeah, well, where they would contact the back.
Okay, so where their butt hits the back of the seat.
Yep.
As Lonnie and I.
I'm going to use this as an example,
Okay.
and this is a really good tool.
Well, what I like to do is I do, measurements, 8, 9, 10, 11, 12, 13, 14. And then what I do is I sit the kid, I abduct him to where I might want him, then I just look back there and it says 12, and then that's the measurement. That's how Dick Steppen and I did so many kids as a routine, is that we would measure and put on their stomach, 12, then we lined them up by their size, and then we lined up the chairs in front of them, and then that's how we fit them.
Kathy, is that on all kids that you're going to see, or is that just kids that need to be abducted?
I think most people feel more comfortable abducting. Not many of us sit this way. Because you're less stable. So you find that point of comfort, that point of balance. Go back to the snowman. There's that point of balance with all kids where you sit them on the table and then you can just feel everything kind of settles in. Then that's that point.
Now, one of the things that we had talked about was the boys when they get 11 or 12, or in that age range. Then obviously the abduction becomes a point of controversy.
Yeah.
And is that the same with girls in respect to, or is there no age limit with girls?
It's funny. It's the same for people. Is the fact that, of course, heavy people really abduct because they have room for their stomachs. But most people find that point where they're comfortable, and it's usually 10, 15 degrees of abduction. Most people sit that way because it is less work. So that's what I'm trying to do, is mimic that. But just remember, if that's where you're going to give them, that's how you got to measure them. Because others will measure this way, and then their seat depth is wrong. And that is devastating for somebody whose seat depth is wrong, unless they're going to grow quick enough that you're not going to notice.
But
Go ahead.
if you have the seat belt, here, and you have the abductor, they're not going to go down anyways. They're not going to slip anyways, right?
If the seatbelt can capture them, yeah. But look, here, it's like the handle on a pail of a bucket. See how close his legs are to his butt? Once I open them up, see how much shorter it gets?
Yeah.
So that's the slop where we have gotten into trouble.
Another question was, do we abduct, or do you use that measuring method on individuals that you're not going to abduct?
Oh, absolutely.
Yeah, it's easy.
Because just like I would do all of you, if I measured every one of you has a point, a rest position where you're most comfortable. If I try to take you out of that position, you're going to try to slide forward, you're going to try to do something else, because it's that position which feels comfortable to you. And it's not with your knees together. Nobody sits with their knees together. Despite what they told me in Catholic school, we don't do it. So, we don't. I'm going to throw out some terms because you need some terms. You'll hear therapists say abduction and adduction. Just remember, add is together and like the abacus to subtract. So abduction is their knees apart. So they say abduction or abduction, most likely abduction. Dorsiflexion when their toe comes up, plantar flexion when it goes down. And then extension away from the body, flexion towards the body. Pretty simple. But that abduction, you'll hear them say it a couple different ways. But I think sometimes we like to say it to people just to confuse them. Hamstrings. Have you heard them talk about hamstrings until you're sick of them? Okay. What is the hamstring? All you need to know is it goes over more than one joint. The pelvis and the knee. The hip flexor and the knee. If it's tight, you have a choice. It's kind of like, do you remember the old Green Acres thing where she's plugging in the cords and they can only add up to 10? And if she exceeds 10, she blows the outage. I've had houses like that. So nobody's ever seen that one. It's hysterical. Yeah, their electrical circuit only has so much juice for up to 10. So it goes through and numbers everything in their house. So she can have the toaster and the light switch, or 2 light switches in the fridge, Anyway, the hamstrings are like that. If there's only so much range that can come through this joint. Now, see this here? This bridging, we call it, the tendon is so tight. That's a hamstring. He's going to sit like that in that picture, but the minute I stop taking that picture, he's going to do what it takes to pull forward because he doesn't want that stretch. So I can have 90 degrees here, or I can have 90 degrees here on this guy, but I can't have both. So I'll show you a couple more pictures so it'll make sense. It goes over 2 muscle groups. So the knee flexor, hip flexor. This is what it looks like. You've seen these guys. Okay, the minute you see these guys, take off the leg rest panel, take that leg panel away, and because you're going to want 90 degrees at the hips. That's your preference. If I try to pull these knees out beyond 90, there's too much resistance at the pelvis because the muscle is contracted. Won't go anymore. And it's a very painful stretch to have here. So here's my little friend. It's hard because the system's black. I have 90 degrees at the knees here, but he's sacral sitting really badly. And I can't pull him back because his hamstrings are so tight. So here are his heels behind here. So if I give up some on the knees, I have 90 degrees at the pelvis and he's set. Easy.
You got the ankles, you got the heels behind the
seat front.
So on a chair like that,
You might have to cut your seat depth a little short. Yeah.
so then you have to rearrange the whole footrest and everything to get him.
Yeah. Well, this is a pretty severe case, particularly for a child this young. But know that, if you just can't get him back and you think, what is that? Well, that's the other thing I'm looking for when I'm putting him on the table. If I have somebody sitting on a table and they're sitting like this, and I bring them forward, and the minute I bring them forward, their heels start to come back. This is a kiddo that I'm going to have to be very careful. Does that make sense? So what happens is, I got them like this, I sit them forward, and their heels will immediately come back. And that's not talking about an equilibrium reaction, that's talking about because of tone. That's also a balance reaction. When you lean forward, your heels come back. But what I'm looking for is that see if the hamstrings are too tight. Because if I try to, what happens is in a lot of chairs, I mean, you can come back quite a ways without the leg rest panel on this. But you'll see a lot of standard chairs where the footrests are out here. It's like a sled. And, but by pulling this, you can never get their pelvis up. Try taking the leg rest panel off and let their heel fall back and see if you can get their seating. It's a pretty common error and mistakes. But people will say, oh, he's got quite really tight hamstrings. But they forget that you've got a choice of range of motion, and I want it in the pelvis because I want a stable base of support. So
you don't want to try and,
stretch it.
you don't want to do this.
It's really uncomfortable.
Yeah.
It's tendons. A couple of reasons. It's uncomfortable because you've got pressure on that bowing tendon
And the
here.
the
That doesn't
angle
feel
on that
good.
chair-
Yeah, have you ever
The
tried to
angle on
go
that
over
chair
stretch?
kept his feet high enough.
Yeah.
That they weren't in the turning radius of the front wheel.
Yeah, that's
Because
the.
that happens with these.
There aren't going to be any more of those chairs for us to play with, unfortunately. So, and here is a block being used with this guy because he has such an immature pelvis. It's the only way I control him. But I've got him pivoted in his chair. I've slid that block right there, and he's not going anywhere. If somebody was to move it forward, and he pulled into it because he's got tight hamstrings, he would not be a happy boy. Right now, he's only concerned that the chair is pink. But you know, that's a rare case, and very few therapists will do that. And that's done to a kiddo who I'm going to be seeing frequently, every day. Fixed versus flexible curves, you know. What is fixed? You look at her and you go, you know, how am I going to position that? Well, are you going to position this, or are you going to handle her a little bit, you know? And it's unfortunate because a lot of times we don't get to handle our kids as long as we want to. And, you know, so motor development. So we're going to talk about the nervous system now that we talked about tone. Know that it's the same brain. And as the brain matures, we go up the scale and down the scale. So from infancy to adulthood, it's the same nervous system as it progresses kind of in its sophistication. So sometimes the postures we see in our kids, if you go to a geriatric facility where they're very involved, they're the same postures because the tonic reflexes have come back and their positions are the same. So that reflexive development occurs, as we talked about. From birth, everything is, bless you, reflexive. And as you develop your neurological system, you get more controlled movements, and it happens in kind of a sophisticated manner. So that when you're born, you're at a spinal level, midbrain level. As your brain matures after you are born, you become more cortical and you get more controlled muscle activities. If something happens and you have a traumatic brain injury, you'll actually get these primitive postures reemerging. And the danger of that, say with a traumatic brain injury, is that you've got normal muscle strength because you've been a normal individual and you have these reflex patterns. And that's when you have terrible, terrible deformities. 3 reflexes I want you to memorize, and they'll save you. Asymmetrical tonic neck. The stimulus is rotation of the neck. It's in the name, asymmetrical tonic neck. It's tonic, remember it's only one-sided, so that when they rotate their head, they get extension on the face side and flexion on the opposing side. Okay, you've seen it. Looks like this. This is the normal baby. So now I'm not worried. She can both directions. This is a kiddo that might have high tone, goes in a stroller, headrest is too far forward, say, and to keep their head up, what do? They rotate their head. And the whole time they're in their chair, they're eliciting this reflex activity. Why is that bad? 2 reasons. They are unstable because it's a phasic muscle activity, and they're burning calories, you know, and it's fatiguing. They give up. So that's an asymmetrical tonic neck. It has a good function in normal development. Rotation develops a child's visual focal field as they follow their hand. It allows them to do some primitive postures, it initiates reaching. There's a real functional reason for it. But once their nervous system improves, we don't need it. But this is what it looks like in our group, right? And very difficult to seat. Now, what could happen if we let them stay in this position? Well, what is this knee going to be doing? You know, and how functional are these arms? Not very. So we want to eliminate the influence of the reflex pattern. Pretty easy. If the rotation is the cause, midline head positioning. So when you hear therapists say to you, midline head positioning, they're not being annoying, or they may be annoying, but what they want is midline head positioning to avoid it. Now here's a little girl. Her complaint when she came to our clinic was that this hip was killing her. Very, very painful. Well, what happened was they had a joystick here. So every time she put her hand down on the joystick, she elicited that reflex pattern, and this hip would come up in deflection.
What is a joystick?
Oh, to drive her power chair. Sorry.
Okay.
This is a very old slide. My favorite power chair. But she just ground away the head of her femur because she was just doing this weird atypical pattern. So, but mid-positioning, you can tell if you get an asymmetry, you know, you don't really want that for a lot of reasons, but it means they're unstable.
Now, is that because she kept doing this with her head?
Yeah, to see what her joystick was. So she would put her hand down, and every time she rotated her head, put her hand down, this hip would come up. And so she was just doing this every time she'd push on her power switch. Yeah. Now this is more subtle. This is the symmetrical tonic neck. And this is why I tell you, don't set your head pad until you get your seating done. This is, for lack of a better description, this is the cat drinking milk. You know, the cat leans over the bowl and lifts their head up and their front legs come up. And then when they put their head down to the bowl, their elbows flex. Kids are the same way. Developmentally, it brings their hands to their mouth as a new infant. It pushes away. If you're going to an avoidance, it's a very functional thing. But if our kiddos have their heads set too far forward, that's the opposing one. I mean, it allows them to lift their head, again, because it gives them strength. You know, they've got this really heavy head, they're newborn, pushing up, they're going to use their reflex patterns to do it. This is subtle. Now here's her headrest here. Here are her elbows. She has a symmetrical tonic neck reflex. The only difference between this slide and the next slide is I move the headrest back a little bit. Oh wait, there. Now if I left her headrest where it was, her elbows would be contracted like that in a very short period of time. The other thing is, what's the other part of that? Flexion of the uppers, extension of the lowers. What you can't see is that she's pushing on her foot plate like crazy. So that when I get to a position where, her arms are down, her head is in neutral, her pelvis is quiet. So if you have a kiddo that's really pushing on their foot plate, go back and look at their head and make sure you don't have it too far forward. It's a really common mistake, where especially when you get tired, and we've done 100 kids that day already, or 200 kids, and we roll in with the headrest like that, and we put them in and go, okay, it's fine. Make sure that it's not too far forward, and that's why we always leave it loose, and then at the last minute we tighten it up, because I don't want to develop elbow flexion contractures, but also I want them to sit in their chair. I don't want them to push into extension.
So how would you tell when that's the right position?
Again, it's that point where you bring the headrest up to a neutral head. You know, you don't bring the child to the headrest, but the headrest to the child. That's not my term, that's somebody else's. It's clever though. Okay, I take license for this because, you know, in the 70s, I don't think we really knew what we were doing in seating. I think we were more desperate to get them off to school. You know, the public law happened and they said, you have to get all your clients off to school. And we were like, in what? You know, Mr. Cabinet Maker made inserts for the beds so that we could actually get them up. That's the level of sophistication we were at. So here is a symmetrical tonic neck in extension. Now, you have to visualize this little guy. He comes to me, he's a baby. He's a cute little baby, but he's got a trach and he has no neck. So when I put him in a stroller and he's got his baby head, he's a cutie, he can't rotate to the side because if he does, these plastic pieces hurt. So he doesn't do that because he wants to balance his head. It's a stroller, there's no place to put it. And he can't drop his head forward because if he does that, he occludes his trach. So what he does is he stacks. And you know these kids, you've all seen them, these what we call stackers, where their heads are hyperextended. That started as a way to hold their head up, to be the snowman, to be that point of balance. Okay, here are his fixed deformities. Extension of the uppers, flexion of the lowers. Fixed. Now, his nervous system continued to progress as he got older. But it doesn't really make any difference because these are fixed deformities. And he can't use his hands for anything because he's fixed. And it came from the positioning. Now remember, he's in his chair 5, 6, 7 hours a day. The whole time he was in his chair, his extensors are going wild. So that's why we want to do it right, because we can actually cause deformities. You know, we don't want to do that. We're not in that business. This last is a third reflex, and that's the tonic labyrinthine. And the labyrinthine is in the ear, and it tells your body where you are in space. So it's my favorite new baby reflex. When you lay them on their stomach, they're all curled up. So prone, or you know, with their labyrinths facing down, they have all flexion. When you rotate them on their back, all extension. I knew I was torturing my son when I was talking on the phone to a friend of mine who's a therapist at Shriners, and she'd say, "What are you doing to this kid?" I was like, "I don't know, I was just playing with this tonic labyrinthine reflex." Because if you rolled him prone, he would be like curled like a little bug. But when you rolled him on his back, he would be all extended and freak out, you know, because he was a newborn. So it's just to be aware of it. And the reason I teach it is because here's what she looks like prone. Oh, here's what he looks like supine. Okay. Tonic labyrinthine is the cause of this. If I roll him over on the side, he doesn't do that. So, is this a kiddo that I put in a tilt and chair, space chair and recline? Because the minute I tilt him back, I'm going to get this tone. That's how we used to take pictures of them for their back to school picture at the state facility. We were so clever then. We were young. Okay, here he is, supine. And you'd look at that and go, "Oh man, how am I going to put him in a chair?" Here he is, prone. Interesting story. This boy, I thought could go into a power chair, and he went to the rehab engineering department, and he came back with a recliner because nobody thought to take him out of his chair. I wanted a power chair, so because he has pretty good head control. You can see him through this pattern. He has pretty good head control. He's just a lazy boy. So, but on his back or in a tilted chair, he's got so much extension because the tonic labyrinthine reflex is there. So that's when I say, take them on the mat, put them on their side, and see if you get a change with these kids with all this tone. Because, I mean, look how flexible he is. I mean, if I go back, I mean, who would think? I mean, I think I have, there he is. Who would think? And then he quiets a little, prone. He's pretty, I mean, he's going to be easy to see. Here's another reflex. You don't have to memorize it, but just be aware of it. If you get something where it doesn't matter where the head is, and you still get this asymmetry, and you find out that they have been injured after birth, this is a reflex that comes from rotation of the spine. And it's temporary. This little guy, hey, here's a Michael, drowned in a hot tub. And it's cross diagonal, unlike the other, where it's flexion on one side and extension on the other. And it comes, if you can visualize a corkscrew, rotation of the spine. And it comes when they have had normal development. They're usually like 2 or so. It can happen with a traumatic brain injury, who's 18, 19, 20. Has huge power because they had normal muscle strength. And when you sit them up, all you want to do is square the pelvis over the shoulders, and the reflex goes away. Because the stimulus is rotation of the spine. Okay. The reason you do it is that after a period of time, 12 months, 18 months, the swelling goes away from the insult, whether it's a traumatic brain injury or an anoxic injury like a post-natal drowning, and then the reflex pattern goes away because it's prenatal. It's a spinal level reflex. It's very, very primitive. Lizards have it.
realistically, I mean, it's good to know, but how often do you think we'll hit that in the third world?
Depends on, yeah, we do get it because these little kids that run in front of a car
Yeah.
or have a meningitis that goes untreated, they were kids that had normal development up to about 2 or 3 years old or older, and then had an insult. And again, the reason you want, it depends on how quickly you can get them, because usually what happens is, this is what they look like. And they're fixed. And the bad thing is, this young man, his reflex went away, but it didn't really matter because his deformities were permanent, which is so sad. Optical writing, this is also a reflex, and you know this one. It's the reason why some of us don't walk around like this, and some of us don't walk around like this. It means that we know what a horizon line is. And there's 2 receptors. One is in your ear, one is in your eye, which means that if you're blind, you don't walk around like this either. You know what your horizon line is. But it means that a nervous system demands that the individual come up to what they consider normal, a horizon line. And so no matter how much I tilt this little boy's chair back, he's still going to come forward to optical writing. And if you have one of these kiddos that's in a tilt chair and he starts pulling forward, and then you start putting straps on him, eventually you're going to just build a deformity. Does that make sense? Because their body is pulling forward. And then they'll look like this. And we see those guys. Because of weakness, they don't pull forward as easily as you normally would have them. I would like to avoid this at all costs. So tilt in space is not for everybody. And so it's an advantage to, again, go back to the snowman. Find that point of balance where you can kind of hold them. Okay, what happens if they can't move? Like you've got them in their chair and they're so locked in and they have the ability to move. Just remember that that's where your fatigue factor comes in and your equipment failure comes in, because they have to be able to move. Pressure relief. We don't really get into it too much with kids because they don't weigh enough to put enough pressure into the capillaries to shut off the blood flow and give us cellular death. So we don't worry about pressure as much. But there are other issues we should be worried about, one of which is moisture and heat, which we can't avoid because of where they live, and friction and shear, where they're actually sliding on their systems. And we'll see some kids with red marks, and people say, well, it's pressure, but you can tell that it's like tearing, where they've slid forward in whatever device they have. And if we can stop that dynamic by using all those things we've learned up to now, we can kind of control some of this. I use a pressure mapper for adults, and that's what it looks like. They sit on a pad, and it gives me this cool little readout here, and then I can see areas of pressure, and I should be doing something about this. I don't have a lot of choices. I always thought this would be a good one, a secondary position. That's not my child. But just be aware that tilt in space does not relieve pressure for a lot of people. Here it is upright. Here's my mapping. Here it is 45. That's worse. And it makes sense because everything is falling to the low spot. You've got to come back behind that, and most of our chairs don't allow that. So if I have somebody who has an issue with pressure, I see about the possibility of maybe bringing them forward a little bit, putting more weight on their thighs. Does that make sense? But, for a period of time, wheelchair companies told us that everybody needed tilt in space for pressure relief. And then we got pressure mappers and went, really? So, and you can manage pressure. We have foam cushions, we have gel cushions, air, you name it. But just be aware that it's probably not pressure. If you're looking at a wound and you're saying, where did this come from? Look at heat and moisture, first of all, because most of our folks are incontinent. And then the fact that they may be tearing or not stabilized in their system.